Not yet. I don't think I can hear anything right now. No, I think the music starts when you start the game. That's my experience has been. Oh, there we go. Can you put the volume up a bit more?
Okay.
Yeah, nice. That's good.
Alrighty, we'll just get the 3 people we have here today. We'll get them to log in. Are you recording already?
Yeah. Did you get a message? I think. Yeah.
Perfect.
I love these names. Yeah, you got the twins this time, guys. You got the power duo.
If I'm not mistaken, we've got a couple more people coming in as well.
Yeah, we've got 4 people here, so we might just wait for the last person. I think just one person has joined right now. If you could just put your if you just log in, and then we'll get started. Hold on, I'm gonna take a picture of this quickly. Yeah, you can start the quiz now.
Start now? Okay. We've got
Yeah.
4.
Okay, starting off nice and easy with some high yield anatomy stuff. So, which of the following organs is not considered to be retroperitoneal? Yeah, well done for everyone who picked green. So this is a bit of a tricky one, I'll admit, but it is actually one of those questions that is super high yield because they can ask this in a couple of different ways in the actual exam. And it goes back to your understanding of embryology when it comes to the definitions like intraperitoneal, retroperitoneal, and secondarily retroperitoneal. So just like really basically, even just ignoring the embryology for a second, the way that I like to think about those terms is when I say intraperitoneal, it's covered on both sides with the peritoneum. When it's retroperitoneal, as it says, behind the retroperitoneum, so it's only covered at the front and it kind of sticks to the posterior wall of the abdomen. And then secondarily retroperitoneal is like a kind of in between. So it was intraperitoneal, but then it moved backwards and attached to the posterior wall and became retroperitoneal. So when I say retroperitoneal, I'm thinking of the mnemonic SAD pucker. So that's probably something that I would have mentioned during the lecture. So if you want to have a look at what that stands for, definitely use that mnemonic because it does help if you don't want to memorize these things. Just for your interest, it stands for suprarenals, which is the same as adrenal. A is for aorta and IVC. D is for the duodenum. Now this is where it gets a bit tricky. So duodenum is only the first part. P is for pancreas, but this is also tricky. It's not the tail. Everything else is retroperitoneal. Ureters for U. C is for colon, only the ascending and descending. And then KER goes kidney, esophagus, and rectum. So for the person who picked head of the pancreas, you almost got it. It's just that when it comes to the pancreas, it's only the tail that is not retroperitoneal. Everything else is. Hopefully that makes sense. And that's why transverse colon is the correct answer. I think I've got a question, which is why do we consider liver intraperitoneal even though it has a bare area? That's a really, really good question. There's a couple of layers to that. So first, it kind of like, I know I said ignore embryology, but obviously the definitions themselves are actually, they stem from embryology. So when we think about the liver, that would have actually, that's an intraperitoneal organ by definition because it would have originated within this, like this, the space of the abdomen, and it would have been covered on both sides. The only thing is because it's so closely attached to the diaphragm, it's just that part at the top, the superior edge or the superior face that doesn't get covered. So you're right in the sense that it's not covered on that space. But if you think about the rest of the liver, it is covered by peritoneum.
Yep. Anteriorly and posteriorly, there's going to be the peritoneum wrapping around it, forming.
Yeah.
This one?
Well done.
Awesome. Next question.
The internal oblique muscle gives rise to which of the following? Awesome. So again, funnily enough, this is one of those questions where really it's just memory. So as long as you know which specific layers of the abdomen give rise to which specific layers in the pelvis, or at least in the male pelvis, the external genitalia, that's really, really helpful, because remember the way that we think about this is that the testicles actually started in the posterior abdominal wall, and during embryology, so like while you're an embryo, the testicles will move down and pass through all the layers of the anterior abdominal wall, carrying all those layers with it. And so it's basically the same layers, just they've been named differently for to be able to localize these things more specifically. So if you know the internal obliquus cremaster, that's really good. But also have a think about all these other options and think about what they originally were in the anterior abdomen. Because again, this question comes up very, very often. All right. Which layer of the anterior abdominal wall is not pulled down during the descent of the testes? Again, very, very high yield concept. Yeah, very nice. So the main thing to discuss here is the fact that the transversus abdominis sort of ends a bit early. If you have a look at a diagram of the transversus abdominis muscle, or in fact, just all the muscles of the anterior abdomen, you'll see that most of them go kind of almost down to the pelvis, even down to the inguinal ligament. So that's quite low into the pelvis, whereas transversus abdominis ends quite early, which means if you imagine the testicles trying to go through, they're not going to hit the transversus abdominis at all. And so all the other layers form part of the scrotum, but this is the only muscle that does not. Okay, well done. What is the lateral border of Hasselbecks triangle? This is a bit of a mean one. Yes, well done. Now, I always had a lot of problems visualizing Hasselbeck's triangle when I was in second year. And the way to think about it is like this, it says like, oh, it's posterior abdominal, no, anterior abdominal wall looking from posterior, like all these confusing terms. But just think about it as you've got the anterior abdominal wall. And if you're looking at it from the inside, looking forward, the Hasselbeck's triangle is sort of on the inside. And the reason why we're so interested in it is not so much because anatomically it's interesting, but because most direct hernias tend to travel through the Hasselbeck's triangle, so directly through the abdominal wall. So that's why we're interested in it. The borders themselves are not too important. The only border that is actually important is the lateral border, which is why we made a question on it. So the inferior epigastric vessels. Remember that when we're classifying your inguinal hernias, whether they're direct or indirect, we kind of use the inferior epigastric vessels as an anatomical landmark. So if it's lateral or whether it's medial to those epigastric vessels. Of course, clinically though, you're probably not going to be able to see those inferior epigastric vessels. So it's more for anatomical significance. There are other tests when you get into the clinic to be able to differentiate between those two types of hernias. Okay, awesome. I should also clarify really quickly that the inguinal ligament does form a border. It's just not that border. I've got a question in the chat. I might just answer it after this one, but it's a really good question. So here's a scenario-based one. So above the arcuate line, what would be the order of your anterior abdominal muscles? I think you can, wait, how many people do we have? We've got 6. Okay. I was going to say you can end the question, but I think there's probably one more response we're waiting on.
I think I'll be a bit too much time for this question. Do you want to... Oh, wait for the response.
Yeah, I think you can skip it. Yeah, I think it should be fine.
Yeah, okay.
Yeah, so with this question, the main thing to understand is the regional differences between the layering of your anterior abdominal muscles in relation to the arcuate line. So again, the arcuate line, the significance of that is the way that your muscles are oriented changes quite drastically at that point. So if you think about above, remember that you have an anterior and posterior layers of the rectus sheath, whereas when you go below the arcuate line, everything becomes anterior. So that's the main distinction. Now, what does that look like? I might just really quickly draw a quick diagram here, just to give you an idea of what that looks like. So the way I like to visualize this very, very easily is if you think of above the arcuate line, think about these two things and think about this as being sort of, what's it called? Coronal? No, axial, transverse. Think about these being like axial sections. So we're cutting through like this. And these two bodies that I've drawn, these two muscles, they pretend that they are the rectus abdominis muscles. So they're going up and down. If you think about above the arcuate line, what happens is you always have the same order of external oblique going around the outside. So obviously that's the outermost layer. Then you've got internal oblique. But over here, what happens is that the internal oblique splits across this rectus abdominis muscle. So I might draw it as the same thing. What happens is it kind of goes like that, if that makes sense. So the outside one that I've drawn was external oblique. These two things that I've drawn, the splitting is the internal oblique muscles, and they join at the very ends like that. And then you've got the innermost layer. Oh, that's really bad, which is the transversus abdominis. Apologies for the really crappy drawing, but there we go. Transversus abdominis all the way at the back. If you think about below the arcuate line, again, you've got the same gross structuring. So you've still got your rectus abdominis, but now everything is in front. So there's no reason for the internal obliques to split anymore. So you just end up having this really nice, simple, okay, you've got the external oblique, you've got the internal oblique, and then you have your transversus abdominis. That's it. Okay. So if I think about piercing above the arcuate line, if I'm going like this, I will hit the external oblique first, then I'll hit the internal oblique, then I'll hit the rectus abdominis, then the internal oblique again, and then finally the transversus abdominis, and then everything below that. Okay, but if it was below the arcuate line, very, very simple. There's only 4 layers: external oblique, internal oblique, transversus abdominis, rectus abdominis. So hopefully that gives you a bit of clarity, but there's also a diagram in the slides, which you can have a look at if you want something that's more anatomically accurate. Which is the most inferior peritoneal space in a standing male patient? So a couple of things to think about here. Yeah, so I've tried to trick a couple of you guys with putting in options like red and blue. And the reason why is because you need to be really careful when it comes to the exams to read exactly kind of like 2 main things. First is, what is the position of the patient? And secondly, is this a male or a female patient? Because that tells you a lot about the pelvic recesses and abdominal recesses that this person is likely to have. So when a patient is, this is very general, but when a patient is supine, you're more likely to get accumulations in the liver recesses, so everything around the liver, because those are going to be the most dependent or most inferior spaces when they're lying down. Of course, if they're standing up, as in this patient, then everything is going to, because of gravity, pull down into the pelvic area. So now you're thinking really simply about what are the pelvic recesses that you have in a male versus a female. Now, in a biological male patient, you're only going to have the bladder and the rectum to really worry about. So really the only pouch that you have is the rectovesical pouch. So recto for rectum, vesicle for bladder. When you have a female patient, you've got 3 major organs in the pelvis, right? You've got, again, the rectum, you still got the bladder, but then you've also got the uterus somewhere there. So now you've got you've got two spaces there. And the most dependent of those in a female would be the rectouterine recess, the blue option there, which is called Douglas's pouch. So if it was a female patient, blue would be correct. If this was a patient that was lying down, whether they are male or female, then red would be correct. So the right hepatorenal recess or Morrison's pouch. And of course, you all probably know that omental bursa is just a fancy term for the lesser sac, which is not really involved with all these dependent fluid accumulations. That's more for when you have, for example, perforated arteries with peptic ulcers and stuff like that, which we will discuss later on. Well done for picking yellow. All right. Which peritoneal ligament is correctly paired with its associated contents? This has been asked before, so I would highly recommend knowing a couple of ligaments, just the really important ones that are surgically relevant. When I say surgically relevant, basically, if you open up a patient and you see these ligaments, you don't want to accidentally cut one that contains like a blood vessel or something like that. So yep, in this case, the answer is red, probably the most important ligament to know. If you don't know any other ones, hepatoduodenal ligament, which is the free edge of the lesser omentum, that's the one that contains the portal triad. Okay, super important. So remember what the portal triad is, and we need to identify that. For example, if we want to cut some of the structures in the portal triad, which is more surgically relevant, not so much here. With the splenorenal ligament, I know it's a bit of a, like I'm trying to make you think, yeah, maybe it's the renal vasculature, but it's actually more the splenic vessels that are going to be contained in that. With falciform ligament, it doesn't contain the umbilical arteries, it contains the umbilical vein. And the hepatogastric ligament does not contain the portal triad because we know that's the hepatoduodenal. So really the ones that I've put here are probably the four most important ones to know, because again, surgically really important to not cut them. The other ones are just, I guess, like interesting to know, but you can take it in one year and chuck it out the other. As long as you've seen it once, that's okay. All right, next question. You guys are smashing it so far. Hey, we've got another player. If you pierce the abdowall below the arcuate line, so we've just done above, and I've kind of drawn a diagram for you, so hopefully we can all get this. Which muscle will you hit first, and which muscle will you hit last? Oh, you guys are all fast on the buzzers. Whenever I get a question like this, guys, just draw a diagram, just in case. If you imagine it, it can be good, but also drawing a diagram makes it a bit more reliable. Very good. So external oblique, then you've got internal oblique, then you've got a transversus abdominis, and finally at the very end, you've got rectus abdominis. Okay, I think out of these options, one of them I put in to trick you for above the rectus sheet. So if it was above the arcuate line, if it was above, then you'd still have external oblique on the outside, but you would have transversus abdominis on the inside, which is option green. Okay, so be sure to not confuse those two. All right. I apologize, guys. Only a couple more anatomy questions to go, I promise. Which of the following nerves is most closely related to the psoas major muscle? Yes. Oh, actually, okay. So a lot of you have picked ilioinguinal nerve. Again, if anyone wants to unmute and let me know why you've picked that, because the majority of you have, I'm happy to discuss. But when I say closely related, this is more like a, it's kind of like something you will come over in specimens where closely related is saying like, which is closest to the psoas major muscle, right? Which is, in this case, actually a nerve that's touching the muscle itself. And that's the genitofemoral nerve. So if you have a look at diagrams of the pelvic nerves, genitofemoral, lateral femorocutaneous, iliohypogastric, and ilioinguinal, the only nerve that will go over the psoas major muscle is the genitofemoral nerve. Everything else passes generally lateral to the psoas major muscle. So if you get a question, which I guarantee you has come up in past papers, that shows you a dissection of a pelvis and there's just a whole bunch of nerves passing through, and you want to kind of quickly figure out which is which, just remember that if you don't remember any of them, the one nerve that passes over psoas major will always be genitofemoral nerve. And everything else, unfortunately, you'll just have to memorize the order in which they go from lateral to medial. All right. One more anatomy question, I think. Which of the following is not found at the level of the transpyloric plane? Yeah, okay. So with this question, I've tried to be as mean as possible, as you can tell. So the transpyloric plane, in terms of clinical relevance, not that important. The only important bit that comes out of this is for imaging. So when you go into your imaging tubes, you might discuss the different anatomical landmarks that occur at this plane. And there's like a huge number of these things that are actually present at the plane, and they're not that important to know. Obviously, when I say transpyloric, I'm saying it's passing through the pylorus. So you know that's going to be one of the things that's present. You do have the L1 vertebral body at that location. You also do have the origin of the portal vein. So that's when the, I think it's was it the superior mesenteric vein and the portal vein join up or something, and then form the portal vein. That happens at the transpyloric plane. The second part of the duodenum is also at that plane. The only thing that's not is actually the tail of the pancreas. It's actually the neck of the pancreas that tends to be at this level. Sorry so much for like I know it's such a small change, like tail versus neck, but it really is quite specific to the neck of the pancreas. These are, again, like similar to the previous question, these are probably the only 4 things you need to know for transpyloric plane. Everything else is very niche. You know, for your exams, these are probably the most important things. So if you memorize these, you're golden. And that's it for anatomy, guys. We move on to systems review stuff, I think, clinical skills.
Yeah, that's me. Is my audio video buffering though slightly?
Nah, it's good. We can hear you.
All right. Here's our first question. So a 9-year-old girl presents to the fever, nausea, and right iliac fossa pain. She said that the pain was around her belly button before. So what does she most likely have based on this presentation? Oh, fantastic. So we have everyone getting the right answer with appendicitis there. So I'll explain a bit as to why appendicitis causes that pain referral pattern. So the way it works is that appendicitis is infection of the appendix. And so initially, because you have that infection, you have visceral afferent fibers being stimulated. And visceral afferent fibers, they aren't as good as localizing pain. So you get very vague pain in the epigastric region, which is what it starts off as. But then as the overlying peritoneum gets irritated by that infection, you also then get that pain starting to become better localized within that right lower quadrant region where the appendix actually is. So that localized pain is because the overlying peritoneum is getting irritated. I hope that sort of makes sense. And the other ones don't really have that pain referral pattern. So like gastric ulcers, you're not really going to get that movement of the pain from the epigastrium. You might get some epigastrial pain, but you won't get it moving to the right lower quadrant, for example. Peritonitis, similar thing. It's actually very different because with peritonitis, you have inflammation of the peritoneum. And so you're going to have generalized pain all over the peritoneum. And probably the main characteristic of peritonitis is that it's relieved by sitting very still. Because if you can imagine, with the whole peritoneal membrane getting inflamed, any sort of minor movements will cause internal structures to rub against it and cause a lot of pain. So the buzzword for that is that the person will be trying to sit as still as possible to avoid causing more pain. And hepatitis doesn't really fit into this pain pattern either. Alrighty. So good job on that one, everyone. The next question is on your screen. Yeah, so this is a bit of a upper versus lower GI bleed question. So what terms would you most likely associate with an esophageal bleed? Oh, nice. Okay, so we've got some confusion about, I think, coffee ground vomitus. So I'll go ahead and explain what the answers are here. I'll define some of the terms first. So hematochezia refers to sort of red, fresh, pink blood within the stool, right? So that will arise from a lower GI bleed. Whereas melena refers to darker, more digested blood. And that'll be an upper GI bleed, blood in the stool, and that'll be an upper GI bleed. Because if you can imagine, the main source of digestion is sort of the stomach and the small intestines, right? Or the first part of it. So if you have a bleed above that, it's going to pass through the stomach first and then end up being a digested darker version when it comes out in the stool. Whereas a bleed below that is going to stay fresh and red and pink because it's not being digested by the stomach's acid. So that's sort of how the stool manifests. Now we have the other two terms, which is hematemesis and coffee ground vomitus. So hematemesis refers to, again, red, fresh, pink blood in emesis or in vomit, whereas coffee ground vomitus refers to sort of darker vomit, the digested blood, essentially. So hematemesis is, again, going to be caused by an upper GI bleed because if you have a bleed above the stomach, that's not going to be able to pass through any digestive chambers like the stomach as it comes out in the vomit. And with coffee ground vomitus, that's usually associated with things like peptic ulcers, where the ulcer is leaking blood out into the stomach, for example, and then the stomach is going to digest it a little bit and make it look more darker, more coffee ground-like. That's why you have coffee ground vomitus there. And I hope that sort of made sense. But if you do have any questions about that, feel free to ask away in the chat. All right, next question. All right, a patient comes in complaining that they have foul-smelling, floating, greasy stools. What could they have? And notice that here I've intentionally left it so that there's a plural there, so you can have more than one answer for this one. Yep. Okay. So most people got this right. There wasn't any answers that were in either red or green, appendicitis or esophageal varices. I'll explain why these two pathologies, pancreatitis and cystic fibrosis, can result in foul-smelling, floating, greasy stools. First of all, for the stools to become foul-smelling, floating, and greasy, the greasy is kind of the key word there because that indicates you've got a lot of fat inside the stool, right? It's also why it sort of floats a little bit and also why it smells so foul because the fat content of the stool is suddenly higher. And the reason you have a higher fat content in the stool is because you're not actually absorbing that fat or digesting it properly. So you have a malabsorptive disorder going on. And there's two ways that they can occur, at least in the answer options here. One is pancreatitis, because if you remember pancreas, they make an enzyme called lipase that breaks down the fat. So if you aren't making that enzyme, you're not going to be able to break down the fat, and hence it's going to be staying within the GI tract and coming out with the stool. Whereas cystic fibrosis has a similar effect where it actually affects the lumen of different tubes in the body. And one of those tubes is the pancreatic duct. And as a result, you're going to have impaired secretions in the pancreas, which means that a similar effect, you're going to have less lipase going out into the gut and breaking down that fat. And then you're going to have, again, those greasy stools. Whereas the other two don't really relate to fat absorption as much. And with appendicitis, again, the key idea there is the pain referral pattern. With esophageal varices, you're actually going to have blood vessels sort of leaking into the esophagus, and you're going to end up seeing blood being vomited up. So that's the key one there. All right, next one. All right, now some physiology questions. All right, this is a bit of a tricky one. So I'll try and explain what's happening here, because I think the key idea here is to really understand the pathways that are going on with cholecystokinin, secretin, all that stuff. So the way I think of it is cholecystokinin is a chemical that's released when chyme, so the digested sort of stuff from your stomach, leaves the stomach and enters the duodenum. So the way you can sort of remember that is you can think of cholecystokinin, the kinin part, as referring to the fact that chyme is going into the duodenum, chyme. And so your chyme is entering the duodenum, and that's a pretty big deal because you have a lot of acidic stuff moving from the stomach into the duodenum, and you want to make sure that you're first of all neutralizing it so that's not going to damage the duodenum, and you're also digesting the fat inside it because that's going to be another important thing you want to do with that chyme. So whenever the acidic substance chyme enters the duodenum, it triggers enteroendocrine cells. And again, we'll stop there and explain what those are. So entero, small intestine, endocrine, cells that secrete hormones. Those cells are going to, in the small intestines, in response to the acidity, secrete secretin. So easy enough to remember that. And that secretin is going to cause the bile ductal cells to secrete bicarb ions. And that's important because bicarb is going to be an alkaline substance that will actually buffer out and neutralize the acidic chyme. And then the fat content of that chyme is also going to trigger the same enteroendocrine cells to secrete a different molecule, which is cholecystokinin, which is the one that we actually care about here. And that has a number of things. The primary thing it's going to do is create a bunch of, perform a bunch of steps that are going to allow it to actually break down the fat. So the first one is gallbladder contraction. That way you're squeezing the bile out from the gallbladder and getting it into the GI tract, where it can actually break down that chyme's fat content. Sphincter of Oddi relaxation. So the sphincter of Oddi, if you remember, is that little end of the gallbladder duct, the biliary tree duct. And if you let it relax, it's going to allow the bile to come out into the actual duodenum. And it's also going to stimulate the pancreas to produce lipase and colipase, which again are going to break down the fat. So all those things are going to be very effective in actually breaking down the fat. Some things which are not listed on here, but are also secondary functions, is that it will also inhibit stomach churning because, again, the chymes come out of the stomach's job is kind of done, so it can stop churning. Then it also can result in pyloric sphincter contraction because, again, the chyme has entered the duodenum. You want to make sure that it doesn't go back up into the stomach. So you sort of close off where it came from between the stomach and the duodenum, which is the pylorus. You close that off, and so it can't go back up and reflux into the stomach. I hope that sort of makes sense. And again, if you have any questions, let us know in the chat. Alrighty. Okay, so a bit of confusion between yellow and green. So achalasia, there's not really an easy way to remember. It's a bit of, I think, just a word you have to understand the definition of. I think chalasia, like the root word means relaxation. So achalasia means no relaxation. So the idea here is that you don't have relaxation of the esophagus. It's like contracted of the lower esophageal sphincter. So it's sort of contracted very hard, and it's preventing food from going down the esophagus into the stomach, right? And if food can't go into the stomach and it's backing up in the esophagus, you're going to have difficulty swallowing, so dysphagia. And then from that, we'll talk about the reason as to why you get that. So the most common reason for achalasia is that you have degeneration of the inhibitory nerve cells in the mind plexus. And so the lower esophageal sphincter stays contracted, and that's what causes the achalasia. In terms of how we sort of resolve it, it's a wiring defect because the nerves themselves are damaged, and there's not really any way to fix that. But what you can do is go in with an endoscope, put a balloon into the lower esophageal sphincter and expand it open. That way you can sort of force it open, allow food to get through there. Or you can use a Botox injection, which essentially paralyzes the muscle. It stops the parasympathetic nerves from secreting acetylcholine. And if you reduce the parasympathetic innervation of the esophagus, you're going to allow it to open up that sphincter. All right, that was that question. Let's move on to the next one. I think Jainam's also talked about what saliva production impairment would be called in the chat. Awesome. So this is again a bit of a thing you have to remember, but the idea is that the parietal cells are very important because they're going to produce something called intrinsic factor, and that sort of allows it to bind to the B12 and allows it to be absorbed, right? So without that intrinsic factor, you're going to have an impaired absorption of vitamin B12. And the reason we care about that is that becomes very important in a condition which you'll probably cover a bit this semester, but go into even more detail next semester, which is pernicious anemia, where essentially you have an autoimmune attack of these parietal cells. These parietal cells are being destroyed, and as a result, you're going to have impaired production of the intrinsic factor. So that means you're going to have impaired absorption of vitamin B12. And vitamin B12 is a very important coenzyme, I think, for DNA production. And if you don't have vitamin B12, one of the main effects is that it's not going to allow red blood cells to form. And you might think red blood cells don't even have nuclei anyways, but initially they do lose them along the way. But to form them initially, you have to have those nuclei. And so you're going to have impairment of red blood cell production, and you're going to end up therefore with a bit of anemia or low red blood cell count. All righty. I think we've got 2 more questions to go. Oh, and we've got one more question here. Yep. All right. So I believe pepsin is secreted by cells in the stomach. I think it's the chief cells of the stomach that produce pepsinogen. Is that right, Jainam? Yeah. Okay. And that's why pepsin is going to be wrong. Everything else is made by pancreas, so that's why it's included there. Yeah. So we'll move on to the next one.
Last 2 questions. Okay. We're just ending off on a little bit of critical appraisal. So which of the following is not an important part of critical appraisal? All right, good. So I guess the only real answer to this question is that critical appraisal is something you do, right? Like you find a paper on Ovid or whatever, like some sort of database, you look at that paper and you're trying to figure out, regardless of what the authors are saying, you're trying to figure out whether this paper is actually something that's accurate and worth drawing conclusions from, or whether the researchers have done something wrong and it's not actually something that is reliable as a source. So when it comes to yellow, analysis provided in discussion, that's cool. Like you can read the analysis that the authors provided, but critical appraisal is something you need to do. So is there any mistakes that the researchers haven't actually included in their discussion? Like, is there any extra bits and pieces that you can figure out from the methodology? That's what actually forms critical appraisal. Everything else is part of that. So you're looking at how recent that research is. The statistical significance is something that you can calculate. And relevance to clinical practice, of course, is all of this kind of coming together to inform whether you use it on a particular patient. So that's why yellow is actually incorrect. Okay. Let's go to the last question, and then we'll open up the floor to questions from you guys. All right. Again, a very important concept, asymmetric funnel plots. What kind of bias is that? All right, very good. So I don't think there's much to explain here, but just remember what funnel plots are. Generally speaking, so they map multiple studies on a diagram, right? And you have your y-axis and your x-axis. Generally, the x-axis tends to be like odds ratios or risk ratio, whatever your outcome of measure is, and the y-axis tends to be things like standard error. So you don't even have to remember what the x-axis and y-axis are, like if it's results or whether it's a dependent, independent variable, whatever. The main thing is that your funnel plot needs to look like a funnel, right? It has to be symmetrical. It needs to be equal number of studies on either side of a midline, because that tells you that there are some studies that show that this potential treatment has like a positive effect, other studies that show that this treatment or whatever has a negative effect. And that makes sense. You're going to have different studies having different results. But if you have an asymmetrical funnel plot, for example, a funnel plot that seems to show that all of the studies or most of the studies show a positive effect of a treatment, that potentially indicates that people are not publishing those negative results. And obviously, there's a lot of systemic problems or reasons why people would do that. But the idea is that your funnel plot should not be asymmetrical. And the only two reasons that it could be asymmetrical is publishing bias, or you don't have enough studies to actually form that nice symmetrical funnel. So very, very well done. The answer is definitely green. So I think that's the end of the questions. Do you just want to show the leaderboard, Janel, like who's got first, second, third? And while we do that, think of what your questions might be. If you have anything for us, feel free to, because we'll wait here for about 5 to 10 minutes. If you have any specific questions.
We'll stop recording as well, right?
Yes, good point. I will stop.